Over the years, what we have seen is that combination of therapies, they tend to work better than a single agent, right? From the beginning, when we were just using 2 drugs, we found out that 3 drugs were doing better than 2. And recently, for those who are newly diagnosed, recommendations are more often that 4 drugs were better than 3. So we start learning that these drugs, rather than be alternative, they are complement. The same thing applies to academic institutions and community hospitals. So when I saw the conjunction or, indeed, there's no or, it's and, right? So I will speculate that it's likely that those patients and caregivers that receive care from both facilities in coordination, they might have an easier way through this journey than just trying to travel to a single academic institution, etc. So, to start with that conversation, I mean, make sure that when there's any consultation, that the communication between your physician, primary physician, and that myeloma specialist is closed, is effective, and it's not only about physicians to physicians, nurse practitioners, nursing staff, the secretary, the one who is responsible for making sure that your records go back and forth. So it's a whole team approach. And when I heard Dr. Gertz this morning giving his lecture, I mean, he's fantastic. I kind of grabbed 3 main points, right? One was diversity, how different people can present with the same diagnosis, especially at the beginning, right? Not every patient with a newly diagnosed multiple myeloma presents in the same way. So there's a diversity of ways, and every situation is a little bit different. So all those aspects that makes a different situation needs to be taken into account, right? So the second point that he touched was empowerment. He was talking about you need to know about your medications, or try to understand as much as you can what the recommendations are. Try to look for clinical trials, look for those organizations where to look for those alternative treatment that sometimes can bring better outcomes. And last but not least, he spoke about team, how it's a team approach what can make you better. And that's the point between academic institutions and community hospitals. If a message you can take from here today is that they are complement, and working together, you're gonna go, you probably will have a better outcome. Now, I was asked also to touch on the topic of relapse refractory multiple myeloma. And at this point in time, there's no known cure for multiple myeloma, although patients, many of them are going to be living many years. And perhaps a diagnosis of diabetes is going to take more importance over the years than a chronically maintained in remission multiple myeloma. So I believe that for refractory or relapse multiple myeloma, one of the best approaches is to avoid it, right? Although we know that ultimately chances are that we're going to have at some point some return of this disease, even if it's just biochemical, right? Even if it's just a blood test that is telling us that those cells are proliferating. Let's make sure that we understand that the more we delayed that relapse, the better we will do in the long run. So, like we mentioned that 4 drugs as an induction appears to give you a better outcome, even for patients who are eligible for transplantation or those who are not eligible for transplant. And even that group that might be eligible but decided not to pursue that stem cell transplantation. So this combination of drugs now, using quadruplet, can prolong your disease-free survival. We want to keep in mind also that there's data now, and what's presented in our last American Society of Hematology meeting. That is an annual meeting where all hematologists, or many hematologists from all over the world come together and share some data, attend presentations, and new advancement. And there was data showing that, especially for high-risk situations, right? Patients with high-risk myeloma, and that is determined by cytogenetic abnormalities, mutations, etc. Perhaps 2 drugs as a maintenance might work better than 1. So the use of a monoclonal antibody, especially those who target CD38, in combination with an immunomodulatory, like lenalidomide, for example, those combinations might deliver longer disease-free survival and can delay even further the relapse or refractoriness of this disease. Now, when unfortunately, despite all these efforts, we have these conditions coming back, and I'm talking about these conditions because I'm convinced at this point, after dealing and managing myeloma since the 90s, that there are different types of myeloma, that we put all of them in one basket, but we all know that there's some certain characteristics, certain mutations, certain presentations that make the disease, the evolution, a little bit different. So when the time comes that we have to confront a relapse disease, your physician and yourself should look into several variables. I always think that for any kind of intervention, there's 3 main factors, being the patient the most important one, the type of disease that we're confronting, the biology of that disease, the risk of that disease, and the therapy that we're trying to use or utilize, right? So when patients relapse for the first time, now we have many options that are effective, right? Many years ago, as I mentioned, I have been managing patients with myeloma since the 90s, and it's fantastic all the tools that we have now and how we need to think on them, right? So the combination of these drugs that sometimes are second generations of the drug that we have used already, combination therapy with monoclonal antibodies, proteasome inhibitors, immunomodulators, for example, they can still give you a second chance, a prolonged disease-free survival, even in the relapse setting. And last but not least, we have now what we call immunotherapy, cellular therapy, that in some fashion, we have been using immunotherapy from the beginning. Even from the days of thalidomide and lenalidomide, bortezomib, there was some modulation of the immune system. However, that modulation was random, right? We were just triggering the immune system, trying to find an effect on the multiple myeloma, and now we have more targeted therapy. Now we have antigens that we go specifically after them, and now we have what you heard by specific T-cell engagers. This afternoon you're going to hear about chimeric antigen receptor T-cells, where they are both kind of tools that are going to take advantage of our immune system and direct that into in a more effective way against multiple myeloma. And we have now a strong immune system that start working sometimes with other type of therapies or in chemotherapies, they don't work anymore. And clinical trials continue improving this effort. Like you probably heard, the B-cell maturing antigen or BCMA directed immunotherapy. We have other targets that these CAR T cells are now pursuing. We have other molecules like bispecific T-cell engagers, and now we have CAR Ts that are using 2 targets, right? Like GPRC5D and also BCMA, because the expression of these proteins on these cells can be different, right? It's like imagine an egg. You have the shell, which is the membrane outside, then the white and the yolk, right? So on the surface, you might have more than one, well, these myeloma cells have more than one target. And the expression, let's try to put it in simple terms, the concentration of those targets might be different. It might be different among patients, actually. And after treatment, might be different as well. So a little bit of complex topic, but the efforts that are put in now in order to take advantage of that knowledge, of that understanding, are fantastic. So now, if there's any question, the intention of this, rather than be just a didactic lecture, is to have a conversation. So I would like to know more about you, and obviously, my opinions are not replacing the opinion of your physician. At the end of the day, something that I have learned is that consultants never know more than your primary oncologist. That they always know more details, and my conversation is going to be in general terms. At the end of the day, you should talk to your provider and have that conversation. Take any information that you learned from this event today and have that discussion with your doctor. But anybody who have a question, anything that we can start discussing?
I am in maintenance right now and on a 2-drug maintenance because I'm high risk. What role does intolerance or, to the drugs that, that you're taking play in changing therapy?
Right. So that is an excellent question, and that's precisely what I mentioned at the beginning, when we need to keep in mind that this is not a one-size-fits-all. That at the end of the day, every patient might present in a different way. And when I have in conversations with some of my colleagues, I bring up that point, that when we talk about relapse disease, it is possible that each one of us has a different patient in mind, because patients relapse in different ways. From just a biochemical relapse, someone that is going to the therapy, to the physician to monitor the therapy, and they find an elevation of a protein, even though there's no symptoms. And patients who start some maintenance and start developing side effects. I remember when someone asked me what will be a contraindication for 2-drug therapy. Tolerability. What about if the patient develop a skin rash with lenalidomide? Right? How much should I push? Should I just modulate the dose? Should I come down on the dose and frequency? Or should I replace this by something different? So fortunately, now we have more than one tool, right? From the immunomodulators, from the monoclonal antibodies, and that is something that can be explored. For example, I have had patients who develop a skin rash with lenalidomide, but when I switch to pomalidomide, the skin rash doesn't come back, even though they are part of the same family of drugs. The same thing has happened with peripheral edema. Swollen legs with pomalidomide, and I don't see that with lenalidomide. So not because they belong to the same family means that the side effects are going to be similar or identical. So one option is to discuss the possibility of switching, even though within the same family, monoclonals or the immunomodulators. And the other aspect of this conversation is for how long I'm going to keep that maintenance. Many of the studies have followed this patient for a couple of years, and that is also something that is debatable, because for someone with a standard risk, great response, go into remission, MRD negativity, right? Even with the special diagnostic tools, I cannot detect the disease, what we call an minimal residual disease negativity. I might feel comfortable holding therapy at that point, especially if the MRD had been tested more than once. Right? In contrast to the patient that took me more than one regimen to achieve that remission. And after partial remission and salvage, now we're in a very good partial remission. I needed stem cell therapy to achieve a complete response. Now I have no evidence of disease, but MRD positivity. I don't feel so comfortable stopping that maintenance, even after 2 years. And in that patient, probably I will use a prolonged maintenance therapy. But as Dr. Gertz also mentioned this morning, you can bring 5 myeloma experts on a table, and everyone is going to have an opinion, right? But I think that's why the conversation and what makes sense for you and your provider are kind of the most important aspect of all this conversation. Any other questions? Yes, please.
I have a question about CAR T.
Yes.
what I know about CAR T, I've learned at one of these sessions.
Okay.
And so it's like a 30-minute overview of CAR T. But it sounds like there are 2 approved drugs for CAR T therapy for multiple myeloma and a clinical trial working on a 3rd.
Yes.
Of the 2 approved, I would assume one was first approved and then along came a second one from a separate drug company. Is that correct?
Yeah.
So does the current thinking for CAR T therapy point you to one of those 2 drugs, or does it point you to a clinical trial for yet a new CAR T therapy?
Yeah. So that's a good question also, because in the same way that now that we have different drugs, we need to think a little bit more into which one we're going to use in the timeline, right? Before, after, because you can try a CAR T now and you might be able to try a CAR T later, right? But which one do you use? Are they comparable? They are not identical, right? That's the first thing that I need to tell you. Because in this target, we used to think that this target that we are following with CAR T or bispecific was a bullhorn, that was the target and that's what I had to hit. And turned out that those targets has many sides, has many angles. You can think on a square, you can think on a pentagon, and even though I'm going after that BCMA, I can hit that BCMA through one side and the other CAR T cell hit the same BCMA to the other side. And sometimes I have a CAR T cell that hit that BCMA from 2 sides, right, etc. And usually what we see sometimes is that we trade effectiveness for toxicity. Sometimes we have a little bit more side effects, even though we achieve a better response in our long-term survival. Sometimes we have to think on that trade and what works best for us. We try to mitigate and minimize those, sometimes by debulking, while trying to get rid of as much myeloma as we can before we jump into CAR T. And that is the basis for some of the clinical trials in where they're using stem cell, trying to control the disease. And this is applied more to very high-risk patients. They present in a more explosive way. Patients who come with high calcium, coming to the hospital, you control the disease. Now they go into stem cell and perhaps CAR T. And those are, again, clinical trials. But what I want to have everybody in mind that, again, all these therapies are complement. And how do we decide between one CAR T and another is going to be based on the patient that I have in front of me. Is this patient handling a CAR T that is associated with a little bit more of CRS, cytokine release syndrome? Does his disease deserve taking that chance? And that's why, I mean, that conversation with your physician, and especially that is something that perhaps a physician who specializes in treating myeloma might answer better than your physician who is a superstar, because the physician who is in the community, treat a breast cancer patient, lung cancer patient, colon cancers, knows about your myeloma, knows about the lymphoma and leukemias. Because, I mean, don't ask me how to spell PSA, right? So those people knows a lot of things. So when you go to a physician who just studied myeloma, of course, he sounds like he's very bright. But that question, absolutely, maybe myeloma specialist needs to be involved. Making sure that your renal function is taken in consideration, again, how much disease is there, etc. But we cannot tell that. There's some trends. There's some analysis that suggest that one might be more effective than the other, depending how you define effectiveness. If effectiveness for you is to get rid of the disease, yes, there's one that appears to be more effective than the other. Right. In regard to side effect, there's one that appears to have more side effect than the other too. Okay. And yes?
Hi. Can you discuss the significance of the free kappa light chain, free lambda light chain ratio in regard to relapse?
Yes. So normally, our bodies, we have plasma cells that protect you from infections. And those plasma cells, they produce a protein. That protein, but to put it in graphic, is like Y letter shape. Those little horns are the light chains and then the heavy chain, right? That can be IgG, IgA, IgD, etc. Now, in our body, normally, some of our plasma cells, those little horns are going to be kappa, and some of them are going to be lambda. Right? That, by the way, is because of the people who discovered them. Those were their initials. They doesn't have to do anything with the Greek alphabet. So yeah, they put their names, right? But our body makes those proteins in a very balanced distribution. It's like a fraction. 1/2 is the same thing that 50/100. So when your body starts making plasma cells that go up, they go up in a very balanced ratio. They go up or they come down. Because those light chains get cleared through the kidneys, when they go up, both goes up. But then the kidneys got better, they both come down at the same proportion. But if you see one going higher than the other, either kappa or lambda, that tells you that there's a cell that is proliferating in an abnormal fashion. It's proliferating without control, and it's not supposed to be proliferating outside of that well balance. So proliferation by itself, we need to be careful because that not necessarily means that you need intervention or whoever needs an intervention, right? Sometimes we follow what kind of impact is having in the individual in order to decide, well, it's a good idea now to intervene, knowing that, of course, you don't want to wait until you see a fracture to then intervene. So there's a level, and that's why sometimes we use more than 100 in order to come up with a diagnosis, and that's what you use sometimes to track these patients. So that's how you start determining and to look into the possibility of relapse, right? But and just to mention that light chains most of the time is used when you don't have the expression of the monoclonal spike, because ideally you follow your monoclonal protein in the serum, right? The entire protein, rather than just the light chain. In some diseases, the cell is so abnormal that only makes light chains. And sometimes you find that light chains only in the urine. That happens at diagnosis, that can happen up in relapse, what we call the escape syndrome, right? So the blood looks good, but when you check the urine, you find light chains there. So it's always a good idea to check that 24-hour urine electrophoresis at least every 6 months or once a year. Okay.
Hi, Doctor. Thank you for being here. I talked to you briefly on the way in.
Yes.
I'm here because I haven't relapsed yet, but I know that day is coming. So I have kind of a two-part question for you. I did quad drug induction. I stopped and harvested and stored stem cells, but I'm not interested in a transplant at this point. So they put me on maintenance. In December, I had a bone marrow biopsy, and I am not MRD negative, but I'm 10 to the 4th, so I know I'm very close.
Okay.
Can that change while you're on maintenance, or would I need a more aggressive therapy to get to MRD negative? That's part one. And then my part two question is obviously what I'm here to learn. When that first relapse happens, what questions or options should I discuss with my care team to know that I'm making the right decision?
So a few years ago, Michel et al., from a French group, looked into stem cell transplantation early or late. Right? And what he found is that on the long run, at least based at that time in medicine, when we have limited number of drugs, because now we have other options. CAR T was not available unless in clinical trials. Having a stem cell transplant at the beginning when patients are diagnosed, like you were mentioning, induction in stem cell, was not too different than having a stem cell later. What was different was not having the stem cell at all. That absolutely, patients have a lower outcome, lower survival than when compared to patients who have stem cell either at the beginning or later. So at the time of relapse, stem cell is something that should be rediscussed again, especially because you have stem cells in storage. That will be my opinion, knowing that, of course, there are other options that are not necessarily stem cell, and the relapse is going to be evaluated based on timing. Right? It's not the same thing to have a disease coming back within the first 12 months, which is something, a term that I didn't hear too much this morning, but the functional myeloma, who are those patients who didn't present with high-risk disease based on cytogenetics, but the disease came back right away, right? So that is by itself a risk factor that is not predictable. You cannot use that up front. You use that later, but certainly it tells you that we need to do something more than the standard, right? And that the two-drug maintenance comes into place, stem cell therapy perhaps, and don't forget this concept that all these therapies are complement. They are not alternative. That at the end of the day, those who got that line of therapy sequentially and doing better, when you hear patients 15 years, 20 years, it's rarely to see a patient like that one because just got induction and was jumping on Revlimid and was on Revlimid for 20 years. Usually those patients went through the whole sequential line of therapies. So what will be the options? Secondary drugs from the same family. For example, in cases in where patients receive bortezomib, they have carfilzomib, lenalidomide, they have pomalidomide, even daratumumab, they have isatuximab, if the time between those is long enough. And for those refractory, now we have the cellular therapies. Bispecific, we have the CAR T, and something that we didn't talk too much about it, but the antibody conjugated drugs, like belantamab, which is a drug that was taken off the shelf. It was a positive outcome, not so positive as they were expecting. There was some side effects. But now at the last American Society of Clinical Oncology, there was some presentations, and they're coming back this ASCO next month. And I believe that that drug is making a lot of noise, and I believe that chances are that it's going to come back because with the changes in dosage and I think and better understanding of the ocular side effects, I think that will be another alternative for patients who have relapse disease.
Okay, perfect. We have time for one more question over here.
I had a bone marrow transplant in July 2020,
Okay.
and I have relapsed. I relapsed last year. And one of the things that my specialist said was, well, you could have another bone marrow transplant. But I was told in 2020 that I couldn't have a second one. But I am on, he has put me on some maintenance drugs. But my question is, how long, can you go if you've had one? What's the time limit to have a second one?
Right. So try to answer this very quickly. When we were collecting stem cells for more than one transplant, that was at a timing where we didn't have too many other alternatives, right? So we thought, if this doesn't work, we're going to have to go back to the same kind of therapy. Now, there's data. I do stem cell transplantation, so you're preaching to the choir here, right? So there's strong data showing that if the relapse happened longer than 18 months from the stem cell transplant, another transplant might give you another prolonged disease-free survival. If the disease comes back within 12 months, chances are that a second transplant is not going to give you more than 6 months. So that option is real, is available. Now, some patients are going for stem cell therapy. Are going for CAR T therapy instead of stem cell therapy. And those cells have been used sometime for something that we haven't discussed, and someone, maybe this afternoon, they will touch on it. Everybody knows about CRS, cytokine release syndrome, neurotoxicity, but there's also cytopenias, right? Low white cells, low red cells, platelets that sometimes patients need transfusions for several months. And it's something that has been done to revert that side effect from CAR T is using those stem cells that were in storage for that second stem cell that never came, and there have been a reconstitution of hematopoiesis and immune reconstitution. So those stem cells are valuable, and I think that it's a kind of you should keep them there. Don't, because usually they call you to see if you want them to throw them away. So don't throw them away. After several years, the storage is too much, right? They said, "Do you want to get rid of them?" I said, "No, I don't."